national level estimates, given that not all states participate. Information from surveys such as PRAMS can add to the depth of our understanding of personal behaviors and other influences on the health of women and infants, including their impact on infant mortality. Next slide. So the background and goals, PRAMS was established in 1987 as part of an infant health initiative when congressional funding was provided to CDC to establish state-based programs. And the overall goal of PRAMS is to reduce maternal and infant morbidity and mortality by collecting information that can be used to influence maternal and infant health programs, health policies, and maternal behaviors. Next slide. And so who participates in those PRAMS surveys? It is women who had a live birth 2 to 6 months ago. They are randomly sampled from birth certificate records. And each month, states sample about 100 to 300 mothers. In Virginia, we usually sample approximately 2,000 a year. And once the data is weighted by CDC, it's said to be representative of about 83% of all live births in the US. Next slide. And so this is just a map of all of the states that participate in PRAMS, and those few states that don't participate in PRAMS actually have surveys that are very similar. They just may not be funded by CDC, but they do have maternal health surveys very similar to PRAMS. Next slide. So specifically in Virginia, we began collecting PRAMS data in 2007. We started to reach the response rate threshold and continue to do so through 2019, which is the latest available year of data we have. So that should say, oh, well, yeah, we started to reach the new threshold, which is 55% in 2017, and we're still reaching that. We currently oversample Richmond City and Blue Ridge, or formerly Thomas Jefferson health districts, beginning with 2017 data and on. We're able to stratify by those two regions only. Otherwise, it is a state-based survey. And the survey consists of core questions that all states who participate ask, and then there are standard questions which can be state-specific. Then we have our steering committee is made up of VDH program directors and coordinators, MCH researchers from universities such as VCU, UVA, state maternal and child health leaders, Medicaid and March of Dimes staff. And this group helps us determine which standard questions should be added or removed from the survey about every 3 to 5 years. And then revisions to the survey are made to reflect emerging issues. For example, PRAMS participated in the Zika questionnaire and supplement in 2016. And we also began a COVID-19 supplement in October of last year. Next slide. And just to give some background on the people involved, we're located at Central Office of VDH in the Office of Family Health Services and the Division of Population Health Data. The PRAMS team is really just me. We do have an epidemiologist who will serve up 10 to 20%. The position is currently vacant, but our perinatal epidemiologist in the division does do some PRAMS analysis. And we contract with Rutgers University's Blaustein Center for implementing the survey, and they do all of the phone calls and mailing for us. And then, of course, the steering committee members are involved. Next slide. Okay, so the majority of women who participate in PRAMS do so by responding to the mailed survey. And while each state is different, the survey booklets are limited to about 14 pages and they fit about 70 to 90 questions. Women who don't respond to any of the 3 mailed surveys are followed up by telephone. And the survey, either by mail or phone, takes between 20 to 30 minutes to complete. And then here you can see just the front and back covers of our survey, the blue in English, and we also have a Spanish version there in gold. Next slide. And I just wanted to provide an example. Like we discussed, there are some questions that are specific to our state. And this is just an example of one that we're asking in this phase, which is asking about Virginia programs. So specific to us, we can kind of take this data and determine, okay, which programs have moms heard about, which ones are they not so familiar with. And so that's just an example of a specific Virginia specific question. Next slide. Okay. I wanted to talk for a moment about the PRAMS Questionnaire Cycle. So the PRAMS collects data in what we call phases, and each phase corresponds to the questionnaire revision and the length of time that the revision stays in action. And over the years, PRAMS has conducted a questionnaire revision about every 3 to 5 years. Questionnaire phases have been affected by various factors, like bringing on 9 new sites in 2007 and bringing on new states and launching a new data collection system in 2012. And then there are plans to respond to healthcare reform and potentially move to asking more questions on healthcare quality assessment that resulted from the Affordable Care Act. And that led PRAMS to only have a 3-year cycle for phase 7 as well. And we're currently in phase 8, which is still being collected. We are not set to move to the next phase until 2022, I believe. And we have up through 2019 data. Next slide, please. Okay, so lots of people ask, why is our data kind of lagging? Why do we only have it right now, for example, through 2019? And so this table just kind of shows the process it goes through. We start off with sampling, which I do in-house. So I get mothers are randomly selected from the birth certificates, and then the sample is sent to our contractors at Rutgers. And it comes with contact information, but a lot of times it's not very complete, so they didn't have to do phone number or address searches. And then the survey is conducted by Rutgers staff 3 times by mail, and then if they don't respond by phone. Then the survey data is sent to CDC at the end of the year. And then the CDC weights the data so that it's representative of all Virginia live births. Then at the end of the year, the birth file is also sent to CDC. So whenever that is finalized by the health statistics team, it's sent for weighting. And then finally, once CDC has gotten to us in the line of other states, it's on a first come, first served basis. They will send our data back and it will be weighted. Next slide. Okay, so why is PRAMS important? Findings from PRAMS analyses can be generalized to an entire state's population whose pregnancies resulted in a live birth. And findings from the data have been used in many ways. For example, to collect population-based data of high scientific quality on topics related to pregnancy and early infancy, to conduct comprehensive analysis to better understand the relationship between behaviors, attitudes, and experiences during and immediately after pregnancy, to translate results from analyses into information for planning and evaluating public health programs and policy, and to build the capacity of states to collect, analyze, and translate data to address relevant public health issues. Next slide. And then how can PRAMS data be used? It can help us increase understanding of maternal behaviors and experiences in their relationship to adverse pregnancy outcomes. We can develop new maternal and child health programs and modify existing programs. It can influence public health policy and help health professionals incorporate the latest research findings into standards of practice, and can help us monitor progress toward local, state, and national health objectives and goals. Next slide. And I wanted to give an example of our what we call data to action. Each year, the PRAMS programs are responsible for submitting 2 data to action success stories to provide examples of exactly how PRAMS data is being used to improve health outcomes. And this is an example from 2018. It was actually selected to appear on the CDC webpage. And so it starts off with our problem, which was that in 2018, our Virginia PRAMS data showed that 49% of pregnancies resulting in a live birth were unintended, and this was an increase from 2014 when it was 46%. And for the data to action story, the Virginia long-acting reversible contraception work group used PRAMS data to create a stakeholder education document. It was shared with policymakers about the importance of preventing unintended pregnancy and the effectiveness of contraceptive methods in preventing pregnancy. Next slide, please. And this is the same story, just continued. The stakeholder education document with our PRAMS data was shared at the General Assembly. The Assembly passed the bill to fund the LARC initiative, and we were awarded $6 million to qualified health centers to increase access to effective methods of contraception. And then just as an update, in 2020, 18 sites have been registered to participate in the Virginia LARC initiative. And the General Assembly approved the extension of the initiative for 2 additional years. And here I just added the link. You don't have to click it or anything, but if anyone's interested, Shannon, if you wanted to share the slides after, that is the link to where the story is on the CDC webpage. Next slide, please. And so this is just, mothers are able to add their own comments at the end of the survey. And I just wanted to provide some examples from moms who've participated in PRAMS. So overall, moms are happy. Those that participate are happy to do so. They are just grateful to be able to provide feedback on their experiences. The big bubble at the bottom left, I found interesting because one of the mothers was a healthcare provider in Virginia, and some of those resources on that standard question that we discussed a little earlier, she wasn't aware of. So just by doing the survey, she was aware of more services that she did not know about. Next slide, please. Okay, and then these are just some additional websites if you wanted to take a look later. The first one is our data tables. We have them on a resource page, and that's updated annually. If you would like to know more about the national PRAMS from the CDC website, that's there. And then just our Virginia PRAMS site on the VDH site in general. And of course, if you have questions, you can email the PRAMS at VDH email address. Next slide. Okay, well, thank you so much for having me, and I am happy to take questions if anyone has any.
Excellent. Thank you very much, Kanisha. Does anybody have any questions for Kanisha? You can either raise your hand or you can chat them in the chat box. I know there's questions. I've never heard this presentation without questions. So I think if you could share with us, Kanisha, how this data could be translated into everybody's use individually. So if they're at the hospital level or the local health department level, how can having access to this data or knowing that this exists, how could they use this to in their everyday work?
Yeah, well, I could see it definitely being used at all levels. It is connected to birth certificate data. And I will say a lot of times it's much harder to get birth certificate data than it would be to get PRAMS. And PRAMS has a lot of those same variables, such as, you know, the whether the baby was low birth weight or preterm, or you know, the type of delivery, whether it was vaginal or cesarean. And so just having that data, and maybe if, you know, you want to see if the rates of, for example, preterm birth or low birth weight have increased or decreased because of maybe a program you're implementing, that can definitely be done. We have also looked at linking some of those PRAMS variables to the birth certificate. So seeing more than what's just included in the PRAMS data set file. And we have used it here to kind of look at whether, for example, race or education or income has an effect on birth outcomes. So pretty easy for us to go in and do some regression analyses and kind of see if there are higher odds of certain health outcomes. So those are all ways that they can be used daily.
Perfect. Thank you. The other thing I want to highlight is Kanisha highlighted a couple of the questions, but if you have any time or if you're familiar or wanting to learn more about this, you can definitely log on to the site and you can see the survey. And Kanisha mentioned there's a couple of changes based on the phase that they're in. But I know that in all the work that I've done, I intimately refer back to this data source. And I think a lot of times we just don't know that it's out there or what questions are asked. You know, so we don't know how to use it or even that it's available. So that was ideally the purpose of today. I still can't believe nobody has any questions. Does anybody have any? Possibly no.
Maybe they need time to digest. I would say to just, if you're interested, to visit our website. There is all of the survey questions are on there. If you see something that you're interested in, please feel free to send me an email. I can definitely pull data for you. Or if you're really interested, you know, it's just a matter of IRB approvals and data use agreements to get the full data set.
Yeah, and Kanisha, we just had a question come in about how would we access the data, and then would you put in a data request, or is it through the website or by emailing?
Yeah, you can just send an email to that prams@bdh.virginia.gov if you're just looking for some frequencies and percentages, or maybe some cross tabulations. I can definitely pull that for you. And as far as if you were interested in doing some research, if you are a SAS or SPSS person and you want to analyze it yourself, at BDH, they just, like when I've given it to professors before, they have to have IRB approval from their school, and then they get IRB approval from BDH. Then a data use agreement is signed, and then I send the data on over. So either way would work.
All right. Well, thank you very much, Kanisha, for taking time and presenting today. And without further ado, if nobody has any other questions, we will give you guys 30 minutes back in today.
Thank you.
Yep, thank you.